All right, Researching Happy, welcome back. This is the podcast all about the stories behind the studies relevant to the research of mental health and well-being. And we really want to look at different perspectives across that really broad field. So this is obviously not just about researchers, and today's a really good example of that. So today we've got Dr. Stephen Carbone, who's the CEO of an organization called Prevention United based in Victoria, Australia. And I invited Stephen on for a number of reasons. Number one, because I think I'm a big fan of the work that he's doing, and I think he attracts a lot of attention to the world of prevention and a lot of respect, I think, for his work around the country. But I really wanted to talk to Stephen because a lot of his work is relevant to some of the research that I've been doing for my own PhD, which was based on this Dual-Continua model of mental health, which if you've listened to the episode with Professor Corey Keyes, you would have heard all about that. And what I wanted to do was, as you'll hear in the episode, was to talk to Stephen about his work, but really frame it within the context of the Dual-Continua model, because I think there's a lot of people around the world, particularly in Australia, who really are starting to see that this idea of how we understand the relationship between mental illness and mental health can make a big difference to the way we think about our mental health services and what that means for prevention rather than treatment and for a number of ideas that we'll get into. I think what I really like about Stephen, as I hope you'll appreciate, is that he really does bring that nuance of bringing together the worlds of mental health, the worlds around the idea of mental health, so mental illness and treatment and recovery, and the pressing need that we for reform and for improvement and greater funding in those areas, but the concurrent need of prevention and well-being services in sort of in that early intervention, but also for recovery as well. And not a lot of people sort of get that nuance. I don't think they really frame it as an either or. Probably comes from a drought mentality or something like that of there's only this small amount of money. How do we best use that money? And I want to spend on my thing, not on your thing. Where I think Stephen really is coming in saying, actually, we need, rather than dividing up the pieces of the pie, we just need a bigger pie. What was really cool, I'm just going to pull it up, was that my, I guess on a personal note, I got the feedback from my PhD examiners. Sorry, give me one sec. Which was accepted with some, now I can't type my password in, hang on. Terrible editing here by me. That's okay. I don't think that counts as editing, but anyway, I got the feedback from the two examiners. For those who don't know, it goes out to professors from around the world who are anonymous to me, and I got a summary from one of them. I'll just cut to the chase that's relevant here. They sort of talk. Here's a quote basically. The issue being investigated, which for those listening is the Dual-Continua model. The issue being investigated has more relevance than many people realize, as it's an interplay between conceptual and empirical work with significant real-life implications for individuals and human service systems. And that's really the whole point. That's why I wanted to start the PhD, because I thought there was relevance on this Dual-Continua model. Again, go back and listen to the episode 1 with Corey Keyes, who really pushed a lot of this stuff forward. And hopefully we'll hear today, you'll see from today that with Stephen, this is the whole point. This is something that I think inspires a lot of his work. And, this I think gives you a glimpse of what we could be doing in Australia and around the world. So welcome to the show if this is your first episode. Otherwise, welcome back. If you've listened to a couple of episodes in the past, really, really pleased with how the show's been going so far, and we've had some great feedback, but really open to more feedback. So please let us know, whether it's in the comments or privately. Like and subscribe to the channel if you don't mind. You can now rate the channel, which is really helpful to get word out about this thing, whether that's on Apple Podcasts or YouTube or Spotify. But most importantly, I think just share this with someone else. You think if you're hearing this and you think this would actually really resonate or really help someone that I know, just share that to them. I think that's the way I want to go about this thing. So kind of like a grassroots approach. So That's enough from me. Welcome and enjoy the episode. All right, so today it is a pleasure to have Stephen Carbone, Dr. Stephen Carbone, here with us on Researching Happy. We've got a little bio about Stephen here. Stephen is the founder and CEO of Prevention United. So he has an extensive clinical experience in mental health, having worked as a general practitioner in Melbourne's west and northwest suburbs, as a medical officer in Victoria's specialist mental health services. Stephen also has experience in mental health policy and program and service development, having held senior roles in the Victorian Department of Health, Headspace, and Beyond Blue. Stephen, welcome.
Thanks, Matt. How are you?
Yeah, good. Had some fun technical troubles in the morning, but that's okay. Here we are. This is all still learning for me. How about yourself?
Yeah, pretty good. Yeah, looking forward to the conversation. It's a great podcast series you're putting together, and yeah, thanks very much for the opportunity to be one of the guests.
No, I appreciate it. So obviously, just to kick off, I think when I asked you to come on the show, you had the same reaction of a few other people that have had the same thing of, I'm not a researcher. And I think I've probably not made the rules clear. You know, I'm the boss, basically. I choose what's what's in and what's out. And this is the idea for the show, is this is all about the world of happiness, and that's not just research. That, you know, there are all these different roles, like translating this and advocating for it. And that's, I think, where your organization comes in. So I thought we'll just kick off just learning a little bit about yourself. So who you are and how you've come to be here.
Yeah, thanks, Matt. I think I've had somewhat of an unusual path. I originally trained in medicine, so graduated with a medical degree, and, you know, as you all do, did my intern year and a couple of years in the sort of hospital system, trying to work out what career path or what specialty I wanted to follow. And I wasn't, 100% sure, but I think I was interested in psychiatry, and so I did do some work here in Victoria in, what we call the specialist mental health care system, back in the day it was working in standalone psychiatric inpatient units. But I was also interested in being a generalist, and so I also did some work in general practice. And so for a little while there, I oscillated between the two, and finally decided probably a career in general practice was for me, but always had a very deep interest and passion in mental health and mental ill health. And so most of my career was really spent as a clinician, trying to support people struggling with their mental health, experiencing mental health challenges and conditions. But I guess I was also fairly interested in some of the more big picture stuff. I guess I'd been a little bit of a political animal and a policy nerd, so did some further studies and got some opportunities. And my first sort of foray into that world was with the Victorian Department of Health and Human Services, as it was called back then, in their mental health branch. So that branch was responsible for trying to, look after and improve the specialist mental health service system here in Victoria. So, so that led to some other jobs, doing some similar things. So I blended clinical work with the policy work, sometimes together, sometimes alternating. But I guess I always had that sort of, focus on how can we do better? How can we make the system better for people experiencing, serious mental health difficulties? And it wasn't until maybe towards the back end of that career that I realised, well, hang on. We've been putting a lot of effort into improving the mental health service system, but, it feels sometimes like we're still treading water. We're still seeing, a lot of people developing these conditions and not everyone improving from them, and always, inquiry after inquiry telling us how bad the mental health care system was. And I then had an opportunity to work at a health promotion organisation called Vic Health here in Victoria, and I guess that gave me a new insight, and it made me realise, look, maybe we need to start thinking about how we keep people mentally healthy and well and prevent mental illnesses from occurring in the first place, rather than just taking this reactive and often crisis-driven approach. So I guess that's what led to the creation of Prevention United. initially more about the prevention of mental ill health, but now equally about the promotion of mental well-being as well as the prevention of mental ill health.
Cool. And so what years were they roughly? I'm just trying to think, was it sort of the emergence of positive psychology that kind of woke you up to some of these things, or was it just what you were seeing for over a number of years?
Yeah, it was more what I was seeing over a number of years, and that experience of working in a more upstream focused health promotion organisation that did focus also on mental health promotion, and then from there doing some further studies, undertaking a Master of Public Health, that sort of really consolidated it. And then it was a steep learning curve. I had to, suddenly go into this new discipline, this new literature, and try to find out as much as I possibly could about this area. And absolutely the work of positive psychology then obviously was front and centre, and has been very influential in how we as an organisation think about this issue now. So I guess I'm a little bit of a late convert to the party, but I'm sort of glad I got here in the end.
Yeah, very good. Very good. And so you're in Melbourne. How long has Prevention United been around for?
We've just gone over our 5th anniversary, so 5 years. But look, we're I guess what you would call a small but reasonably influential organisation. There's only at the moment 3 staff members, including myself, but we have also a great team of volunteers and other people who do some contract work for us from time to time. But I guess because I've been working in the mental health system for a considerable period of time, it means I've been able to establish some good connections and relationships with people, and that has helped helped our work in trying to get the promotion of mental well-being and the prevention of mental ill health on the radar, and really no one organisation can do it alone, and so we have been trying to establish partnerships, collaborations, and having had that experience of working with so many of the more senior people in the mental health sort of community has been useful in terms of enabling us to do our work.
So this is probably a silly question, and I actually should know it anyway, Stephen, sorry about this, but what is the exact goal of what you're aiming for at Prevention United?
Yeah, look, that's a great question. As I said, originally it was about the primary prevention, stopping mental health conditions before they start, trying to prevent depression from occurring, trying to prevent anxiety disorders from occurring, trying to prevent whatever disorder we could from occurring. But obviously, the science tells us, more about certain disorders than others at this point in time. And so it was really to try to decrease the incidence and then the prevalence of mental ill health in the community. But as I said, I think, the promotion of mental well-being and the prevention of mental ill health overlaps so much. I mean, I know they're different endeavours and they come from different, in a way, starting at different points of the mental health continuum or different quadrants of the mental health continuum, that, but there's considerable overlap. So it's now also about, doing, encouraging actions that then also promote flourishing, prevent or avert languishing, in addition to the prevention of mental disorders where we can.
Cool. Yeah. So I mean, that's the perfect segue of where we wanted to go with this episode. So when I got in contact with Stephen, I was basically saying, like, there's this Dual-Continua model of mental health. We've talked about it a fair bit on some of the other episodes. Obviously, we talked with Corey Keyes to kick off the whole show. I thought we could go into a little bit of some of the theory that's come out of our research. And I thought it would be extremely boring, basically, if I just stood with a bunch of slides and presented that. I think that is not my strength, to be engaging to a camera. But instead, I thought we could use it as a bit of a tool for a conversation, and that it could be basically a springboard to hear what this means from Stephen's perspective and from his work. But just before we get into that, I thought, and also not to mention us describing slides and graphs and stuff is going to be interesting for the audio-only listeners, but hey, we'll try our best. Your message is prevention is better than treatment, I guess. That is or maybe, I don't know if you would disagree with that. Maybe better is not the right word, but more optimal.
It's at least
more
as
desirable.
good as, I mean, certainly, look, we're in a situation where, where we are fortunate in that there are some good treatments for a lot of mental health conditions, but by the same token, they're imperfect. Not everyone experiences full recovery, and even people who do often experience recurrences. And there's an emotional drain to experiencing episodes of severe mental ill health. There's a, financial strain. So ultimately, like any condition, if we can prevent it, it's probably better in the first place to prevent it from occurring, even if we do have the tools to try to support people through to recovery.
And I guess that's just my question before we get into the slides is why, basically, do you ever come across someone who disagrees with that idea? I'm going to assume no. I should let you answer that first.
Yeah.
Or let me finish the question. Sorry to jump in. But basically my point is I don't think you would find many that disagree with that statement, yet we don't seem to be seeing any change in that direction.
Look, you're right. No one would disagree, but I think it's really interesting that a lot of people, it still strikes them as, I never thought of that. I never thought about the prevention of depression or the prevention of anxiety disorders, eating disorders. I think we're, in the physical health realm, we totally understand that. We all know that, it's important to prevent the spread of COVID. It's important to try to prevent road trauma. It's important to try to prevent cardiovascular disease, and cancers. But for some reason, I think in the public and also the political mindset, it's almost like, well, mental health conditions are different. They just sort of happen, right? And then you deal with them after they've happened. And they're sort of a bit sort of like, double take. Oh, okay, maybe you're right. Maybe they're not inevitable. Actually, I never thought about the fact that maybe they actually could be prevented. So, there is this sort of like, of course, support. But I think, what we're dealing with is a sort of low level of well-being and prevention literacy, and therefore an uncertainty about, well, okay, so how would you do that? Some skepticism, but it's also, I had never thought about that, so tell me more, how would we approach this? And that's when you can start to have the conversation, and and then it is a question of trying to explain, what we know about the evolution of mental health conditions and risk and protective factors, and how we can intervene in that chain, that causal chain, to sort of try to avert those trajectories from occurring.
Interesting. And so where do you think you see that? Like, is it at the sort of at the clinician level? Is it at the policy level? Because I think the caricature, the bad caricature of when we talk about, well-being, it's kind of like clinicians never thought about well-being before. And now we've come along and now we've told them to do it and now they're doing it. Like, it's obviously that's not the case. We often find that most clinicians probably have an eye on well-being. They have an eye on prevention, but it doesn't seem to be something systematic. It seems to be at the level of the individual practitioner. So where do you see that, that kind of, that idea of like, I never thought of that?
Yeah, look, it's a great point. I mean, look, I think it's across the board. I think it is amongst the general public. I think it's sort of amongst clinicians, but as you say, maybe to a lesser degree. And it's also amongst sort of decision makers, bureaucrats and politicians. But again, I think that's changing. If you look back in Australia's mental health policy, the concept of what was called promotion, or promoting mental health or mental well-being and prevention, appeared for the right at the first point of our national mental health strategy. It was part of the first national mental health plan in 1992. So it's always been this idea that we should be doing this. But the problem is it was never backed up by actual action or funding. And almost always, it was almost like tokenistic. We've got to say this, it's, of course we want to promote mental health and prevent mental illness, who doesn't? But it was never turned into concrete action along the way. And so first national mental health plan, second, third, fourth, they all talked about promotion and prevention, and then in the fifth it fell off the radar completely, which was almost like, well,
really?
At least you're being honest now.
I didn't realise that.
Yeah, well, and we did have this sort of heyday period around the turn of the millennium, 2000. We had an actual national action plan for for promotion, prevention, and early intervention. But again, most of the energy then went on to early intervention. That for me is the early detection of a threshold disorder, someone who has actually got a clinical mental health condition, and then how do we intervene as early as possible and provide appropriate, intensive, comprehensive support. So even after that plan, which was a very detailed and comprehensive blueprint, promotion and prevention really didn't kick off. It was early intervention that did. So I think people have struggled because, maybe there wasn't, to be fair, enough research to back up some of the things that we wanted to do.
Yep.
I think, we've now had a couple of more decades of really good, helpful research that provides a better clarity around how we can get to where we want to get on these issues. But I think it's also because, we all know from the comments from the Productivity Commission, the Victorian Royal Commission, there's this sense that the mental health care system is broken. And so, governments obviously need to respond to people in the greatest need, and you can't ignore someone who's suffering and needs help right here, right now for their mental health difficulties. And so we always seem to be, trying to fix a broken system, and we keep kicking promotion, prevention down the road. We'll come to that. We've got to start here. We've got to look after people who are struggling. And that's okay, but after 30 years you think, well, when's it going to come onto the radar again? And it's almost like, I think it's a bit of a myth now that, we're going to fix this mental health crisis in Australia just by investing in more mental health care services. So clearly I'm not for a moment suggesting we don't need to pour more money into, psychological services, mental health care services. Of course we do. But if we think that that's the only way forward, and if we just do that a bit more and a bit better, suddenly everything's going to be hunky-dory, we're just kidding ourselves.
Yeah, it's like, I think the first thing you learn in Public Health 101, I think, that's going back a few years for me, and I probably wasn't really paying that much attention, I think, at the time, but, the cliff, and are we putting fences at the top of the cliff, or are we putting ambulances at the bottom?
Exactly right.
And no one disagrees. It's funny that you pick up something there, which is how competitive the space is. And so everyone is advocating, I think, correctly for what they need more of. And so somehow it's perceived as you say, I get the sense that when you say we need more prevention, the clinical space says, well, that better not come out of our budget. And I don't think you're suggesting that should be the case, right? Like,
totally, and that is the problem. We've been, as a sector, undervalued, under-resourced, and it does create that sort of sense of competition or, but, we've got a problem here, what about that? And, it's almost like, it's not quite, I'm sort of caricature, this is a bit of a caricature, but it's created this sense of, we need to compete for the scraps. And so clearly our approach is to say, look, let's work together on this, and let's accept that what we need is this strong continuum, of approaches that start at the promotion of wellbeing, the prevention of mental ill health, and then go on to, early intervention for clinical disorders, recovery support, suicide prevention. It's not one or the other. It's all of those things together that we need. Yeah. And that is sort of, we also need to understand that we approach those things in slightly different way. Again, I go back to the physical health world analogy, and there we're very comfortable with the notion that we do, health promotion / public health, and then we do health care, right? We try to do slip, slop, slap to prevent some, skin cancer, but then we have dermatologists and plastic surgeons and oncologists treating melanoma and other skin cancers, right? We don't say it's one or the other. We encourage people to eat healthily, exercise regularly, not smoke. but we all, to prevent heart attacks and strokes. But we also have cardiologists putting stents in people, and people are on, anti-cholesterol drugs, etc. We don't pretend that it's one or the other. But in mental health, for some reason, I think we've tried to pretend that, it's either or you can't have both. But what we really need is, a two-pronged approach. The mental health promotion, and as a field of endeavour, I think is about promoting wellbeing, preventing mental ill health, raising people's mental health and ill health literacy. And then you've got mental health care, which is the more traditional GPs, clinical psychologists, psychiatrists, etc., including now peer workers and psychosocial support services, providing that wellbeing type of support. So I think I'm seeing a change. I'm definitely seeing a change across state governments. They're now, I think, very aware of this issue, that we can't just keep trying to plug holes in the dam wall. We need to start earlier and try to be proactive and keep people mentally healthy and well and prevent mental ill health. So Victoria, I think, is moving ahead very progressively on this issue. Western Australia is. But I know other states are not far behind. I think my concern is that the federal government is still a laggard. And, if I'm going to be critical of any tier of government, I would be critical of the federal government. They are simply just not accepting this logic and not really doing anything active about it. And that, for me, is a big disappointment. They should be doing much better. They should be leading a national approach to promotion and prevention, but they're not.
Yeah, and I guess I'm just going back to your physical health analogy, things like slip, slop, slap. I'm not sure if people from around the world would understand that one, but that's one of our, would people call that one of our most successful health promotion?
Oh, definitely. Look, I think Australia's led the world in health promotion around, the prevention of skin cancer. So slip, slop, slap is about putting on sunscreen, wearing clothes or protection from the UV light, staying out of the sun, at peak UV times. So every kindergarten, every school, every, sports club in this country has implemented measures to try to protect people from harmful UV exposure. That's a massive public health victory, for a country that, has so much sunshine. We need to protect our skin.
Yeah. And so then I guess that's where I was going, is something that's the model of success, or something like the model of success. I assume that wasn't done at the state level. That was done at a federal, national level.
Well, it's done in concert. I mean, there's national leadership and state implementation.
Okay.
This is one of these problems here in Australia as a federated country. Who's responsible for what is always this big question. And look, I think mental health care is a shared responsibility between Commonwealth and state governments and territories. But likewise, I believe mental health promotion should be a shared responsibility. So I don't think, take for example the focus on suicide prevention, which I think there's very strong parallels, and you could potentially put part of suicide prevention in this mental health promotion space, as in the non-clinical care service delivery component. Now, the federal government is absolutely leading the way on suicide prevention. They've established a National Suicide Prevention Office in the National Mental Health Commission here in Australia. But then every state and territory also has its own jurisdictional suicide prevention plan and approach. Yeah. So that's a perfect example of, Commonwealth state cooperation on a particular issue. So I can't see that it shouldn't be the same sort of model for the promotion of mental wellbeing and the prevention of mental ill health. And we've got to stop trying to say, oh no, it's your responsibility. Oh no, it's your responsibility, because that's what happens in this country. The two top tiers of government keep handballing between each other, and nothing gets done properly.
Is it also a challenge as well that, as you say about the responsibility, that the responsibility of wellbeing doesn't, not only does it not lie at one level of government, it also doesn't sit comfortably within just one government department. That seems to be part of the issue as well.
Absolutely, Matt. I think you're spot on there. And look, this is, we're starting to get in some of the complexities of this issue. So I'm not standing here pretending that we can promote everyone's well-being and we'll get 100% of the population to flourishing overnight, or that we can prevent every mental health condition and, and put the incidence and the prevalence down to zero. That's ridiculous. I mean, because we haven't done that for anything, whether it's heart disease, strokes, cancers. But it doesn't mean that we can't work towards that, and the more we do, the better we'll become. The more research dollars we invest, the more knowledge and interventions we'll be able to create. So I think it's really just this issue of needing to make a bit of a start and then learn as we go and build on the evidence as it accumulates. So. But I don't quite think I answered your question. Take me back to that one again. Sorry.
No, just about... I like the realistic thing, because I think firstly we can be a little bit... what would the word be? Like almost utopian or something, like if we just listen to me, man, we'd make a difference, The question was around the whole shared responsibility across departments. Yeah,
so what we know, to overly simplify it, is that it's sort of almost like a balancing act between, positive influences on mental well-being or protective factors and negative influences on people's mental well-being, which we call risk factors. And, we've got to, as the old song says, accentuate the positive, eliminate the negative, right? Now, easy to say, a bit more complex to do, because obviously when it comes to our mental health compared to our physical health, there's a lot more variables or a lot more factors that influence our mental well-being. For example, compared to, our heart health, where it might be high blood pressure, cholesterol, smoking. For depression, it's a whole host of things that can contribute to depression. So it is a much more complex exercise to sort of try to modify or rebalance the various positive and negative protective factor, risk factors. And all of these factors sort of exist in different environments, in the home environment, in the learning or school environment, in the workplace environment. So it can't be one organisation or one sector or even one tier of government or even one department that can manage all of those various risk and protective factors. And so, the problem with the promotion of mental well-being and the prevention of mental ill health is that it does require a collective, joined up, whole of government, whole of community approach. And that's when politicians' head starts to spin, because they like simple things, they like to keep it simple. They like a program that is, they can launch and is going to solve this problem. And they're getting better. I mean, I know I'm sounding very critical of the political class, and maybe I'm being unfair, but it feels to me that, we could solve this problem by taking a more joined up approach, but politicians and departments tend to still work too much in their own little isolated silo. Education doesn't always talk to health, health doesn't always talk to mental health doesn't always talk to, environment, etc. So we need a collective, whole of government, whole of community sort of approach if we're serious about the promotion of mental well-being and the prevention of mental illness, because at the end of the day, it is a complex process, and we need to be able to shift so many risk and protective factors. No one, part of the system can do it on its own.
Yeah, look, and I don't think I think you're being critical of the system itself, that it's just, at the end of the day, it's structured in departments which are silos, and the people within them don't have very many incentives to step out of those silos.
Yeah, and again, I think we're starting to see some glimmer of hope, and we're seeing some models emerge, like wellbeing budgets, where we're seeing that's about taking, again, collective government action. Every portfolio, every department, you set certain outcomes, and then you say, how is this department, how is this team, how is this entity going to contribute to that outcome? And so it's a much better way of doing things because it's not, handing responsibility to just one part of government and saying, all right, over to you guys, you're going to fix this. And then they don't have the mechanisms to actually influence some of the other environments where change needs to happen.
All right. Yeah, agreed. All right. So I'm just thinking, let's have a go at this slide thing. So I don't know, are you a sports fan?
I'm an AFL fan, and I know a little bit about other sports. So
okay,
yes.
Who do you support?
In the AFL, I support Essendon Bombers.
Okay, very good. All right. So what I'm thinking is basically the structure of like a special commentator is kind of what I'm thinking in my mind. So have that. You don't have to come up with the one-liners so much, but I'm going to share this screen. So this is just like a sort of a standard presentation that I've got. Hopefully you're seeing that.
Yeah, it's on screen now.
Cool. So why don't we just sort of work our way through it? So what I really wanted to get to was to talk a little bit about this Dual-Continua model, because I think it's something that is gaining traction in Australia, at least. I think there are certain areas around the world that are adopting it, and it's it's obviously still a simplification. I think you'll see I've got some slide with some cartoon characters on there at one point, and if you're seeing a slide with cartoon characters, it's probably still a simplification. But it's moving in the right direction. I think it's moving in the direction that that is resonating, linking the promotion of well-being with the treatment and the maintenance of mental illness. So is that model, would you agree with that so far?
Look, I think there is the dual continuum model, I think, absolutely assists both with thinking about how do we promote mental well-being across the population, and that includes for people who do maybe currently have a diagnosis of some form of a mental health condition, as well as the general population, and absolutely also helps for the prevention of mental ill health. It's just a good organising framework and a way of thinking about where we need to put our energy.
Yeah, great. Okay, so like I say, I'm going to sort of run through the slides. You can just chip in with any special comments along the way, anything that kind of triggers in your mind or experiences, because I think you've got such a wealth of knowledge and a bank of experience, Stephen, that I want to kind of see what this brings up for you, and talk about it in the context of your work as well, things that you've had successes, because I think we haven't got to that just yet, but let's kick off. So the first slide here, I'm going to try and describe the slides roughly. We might give up halfway through and I'll just say go to YouTube and watch this thing, but basically the first slide here is this idea of the burden of mental illness. So Alexandrova, professor in the UK, has this kind of quote that I've seen, that good mental health is a universally valued outcome. So that's the start point. This is valuable. I think the WHO says there is no health without mental health. You have variations of this thing. This is really important, basically, full stop. The next is then we look at Australia. 45% of Australians will experience a mental illness in their lifetime, with something like 1 in 5 experiencing mental illness at any one time in Australia, most commonly depression and anxiety. So that's sort of 20%. But a recent report came out updating these figures sort of post-COVID. Do you want to talk about that a little bit, Stephen?
Look, yeah, the most recent robust data that we've got from the National Study of Mental Health and Wellbeing in Australia shows an uptick in the prevalence of common mental disorders, particularly amongst young people. In fact, over the period, and it was a fairly long period between the last national survey in 2007 and the most recent survey, there was a 50% increase in the prevalence of, depression, anxiety, substance use conditions combined. And when you break it up, substance use conditions actually went down. It was anxiety that went up considerably, as well as depression. So, there's various issues there. Part of the data collection was happening during the first wave of COVID, which may have distorted the data. But as you know, this looks back in the 12 months before the interview with the person, doing the diagnostic schedule. So, and I think other data also reflects the same thing. There's been a trend towards an increase in mental ill health, particularly amongst youth, and also self-harm and suicide. So very concerning upward trend, particularly amongst young people.
Yeah, absolutely, and that's the point, isn't it? That these statistics are they're damning enough as they are, but it seems to be getting worse. And so I guess that's where I think I started this podcast saying that we have a problem to fix, basically, and particularly the frightening prospect that these rates are highest in our youngest people is a real concern.
Absolutely.
So next, I guess on the slide is this idea. It's just some comments from different international groups around the world. This idea that there's been a lack of progress in reducing the burden of mental illness, and that's prompted calls for improved access to quality mental health care and assessment of mental disorders. So that's really this comment that a lot more money is going into this, but like you say, the ambulances and the fence, or I think I said that actually, despite the addition of ambulances, which are important, that we're not seeing any reduction in the people who are falling off the cliff.
Yeah, look, I think, as you know, we're two things. Just we're trying to come up with a slightly different analogy because of, unfortunately, that sort of implication there with self-harm and
sure.
And suicide.
Yeah, that's fair.
But the point you're making is absolutely valid, that there's this growing awareness now that, despite increased investment and despite increased uptake of service and increased service provision, we're not necessarily, it's called the mental health paradox, we're putting more money into the system and people are using services, but we're not necessarily getting the falls in population prevalence that we'd expect. Now, some people suggest, well, you're never going to get a drop in prevalence because mental health conditions are episodic and there'll always be someone, in the midst of an episode, that they're chronic, recurring, relapsing conditions. But I'm not sure I agree with that, and I think, what we're seeing is a failure to make inroads into incidence that is then, part of the problem that we never get on top of prevalence. So we need to, stop as many people developing these conditions in the first place, and there's no doubt that is a worthy and important ambition. But of course, as we said before, we can't prevent every, mental health condition from occurring. And so, of course, we need to have high quality mental health care for those people who experience those challenges. I mean, the academics talk about, 3 big or 4 big gaps. There's a prevention gap, there's an access gap, there's a quality gap. They tend to talk about those 3 gaps. I believe there's also just an innovation gap, where we're not producing better treatments. We've got much of the same treatments that we've been using for decades, and we haven't necessarily nailed how to provide better quality mental health care services. So I think we've got this sort of research and innovation gap as well. We just need to get better all round across the whole continuum from wellbeing through to recovery support.
Yeah, no, I appreciate that, and I'll stop with that analogy. By the way, that was a good point. I hadn't considered that. And this is the other thing. A bit of nuance here as well is that people hear this, and I think they take that directly as a criticism of you're saying that our services don't work, and I don't think that's the point here, is it? Oh
no. The individuals working in mental health care are such dedicated, hard-working, undervalued, under-resourced people here in Australia. Like I said, most of my career has been doing that, and I continue to respect and admire and take my hat off to people on the front line providing mental health care services. We're not saying that at all. It's not something that people are doing badly. It's a system issue. We need to take the personal out of this. It's about looking at this from a objective systems perspective, and I think we need to find a solution at a systems level rather than saying this person or that group or that profession isn't doing a good enough job, because of course they are.
Yeah, no, I appreciate that. Just important to clarify. Cool. And then, so the last one here is this. This was a call from the US Burden of Disease collaborators in 2018, saying that they were calling for programs to prevent mental disorders and promote mental health. And I always hold on to this quote because it's the thing that is the fundamental distinction that I think we haven't nailed just yet. What is preventing mental disorder and what is promoting mental health? And hopefully that's where I think the Dual-Continua is the next step in the line of progression to start to clarify that distinction. So next slide. This is kind of the caricature of traditional psychology. You've got the little apostrophes there. The kind of the criticism of the clinical psychology to date, or this is kind of, I guess, more around the 2000s when positive psychology was really sort of becoming formalized. This idea of, it's focused on what goes wrong with people. It's about identifying and addressing symptoms of disorder and mental illness. Like we've already said a couple of times, that's not all that our clinical health services are focused on. Definitely not, but that's kind of the caricature, I guess, of it. Wood and Tarrier in 2010 saying that the clinical field has been primarily focused on the assessment and management of dysfunction and distress. I think that's probably a more fair way to say it in terms of like primarily focused. But there has been this recently renewed emphasis on positive functioning and understanding when people are at their best. And that's about reorienting research and practice towards the positive aspects of mental health or mental well-being. And just a caveat there that I know, hopefully I'll get into it at some point. I've got someone in mind who I think can speak to this idea that actually the earliest clinical psychologists were all about, positive functioning and like living best lives, that kind of thing. So yeah, maybe we lost our way along the way. Sorry, Stephen.
Yeah, no, look, I agree. I think, as you've no doubt gathered, I'm definitely a believer in, an eclectic approach, that we value different disciplines and different contributions to understanding this issue because it is very complex. But I don't think anyone's, it's not either or, basically. We've got a lot of understanding, and we need to be able to integrate that understanding rather than trying to preference or privilege one way of looking at things. I think you're right. There has been this tendency to focus more on biomedical type models, which are about disease and dysfunction and therefore diagnosis and treatment. But, a lot of people their lives have been saved by effective treatment of bipolar disorder or, schizophrenia, etc., depression. But yes, I think at the moment we've got a bit of tunnel vision and we're only concentrating at the ill health end of the spectrum and thinking that, obviously the common thing is not recognising that the absence of mental illness does not equal the presence of mental well-being. That's the point.
Yeah, absolutely. It's that scarcity mindset, isn't it? That
totally.
There's only this tiny bucket that we're all competing for, and it's surprisingly hard to have that narrative of, everything that's out there right now is useful, it is effective. We need more, but the more, it's a funny way to get across people's mind of like the call to say we need more is not to denigrate what's there already.
Correct. And when we do our advocacy, we make it very clear that what we're calling for is greater investment in mental health all round. And, one metric that's commonly used here in Australia is what percentage of the overall health budget does mental health funding get? And it's at the moment hovering around the low 7% mark. Whereas, the burden of disease studies tells us that, mental ill health, carries at least 12% of the burden of, injury, disability and mortality. So our idea is, well, let's increase let's grow the pie for everyone. We believe that, the mental health budget should be expanded to at least 10%, of the health budget rather than 7%. But then what we're saying is we need to slice that pie up and give some to each of the segments of the continuum. And all we're asking for in terms of promotion and prevention is 5% of that mental health budget. So at the moment we get less than 1% of the mental health budget to do promotion prevention work.
So of the 7%, 1% of the 7% goes to prevention.
Correct, yeah.
So someone can do the maths of that.
Yeah, so look, what we're saying is mental health as a sector, as an area, from top to bottom, from wellbeing to recovery support, is underfunded compared to the importance of good mental health in our lives and the impacts of poor mental health and mental illness in our lives. So governments just need to understand it's way more important than they are recognising. They've got no trouble pouring money into cancer and heart disease, and I'm not questioning that, but they have a real problem, seemingly, pouring money into mental health. And by mental health, I mean the whole spectrum from well-being through to mental ill health. So it's just an undervalued area, full stop. And then, as you say, then that scarcity creates competition, and no, we need that money here, you don't need it there, or that's not going to work, this is going to work, or we deserve it more than you do, et cetera, et cetera.
Interesting. Yeah, that's interesting. So you're sort of calling for a 5%, a fivefold increase in prevention funding, but within the context of what you're asking for the entire mental health system, that's nothing compared to what you think needs to be expanded for the services.
Exactly. You just grow the overall pie so that we're not got this scarcity, and then you can start to more efficiently and reasonably rebalance the funding that then goes to the different parts of the continuum. But unless you grow the pie in the first place, you're still not going to make any headway. So first of all, grow the proportion of funding relative to the overall health budget that mental health gets, and then divide it up more equitably, more rationally in terms of upstream as well as downstream.
All right, interesting. That was good. I didn't know about that. All right, cool. So this is kind of the what do we call this? I guess this is the question that we're sort of trying to deal with, is the relationship between mental health and mental illness. And so this comes from a quote in 1951 by Eaton in the book The Assessment of Mental Health. This idea that mental health merges imperceptibly and gradually, like the colors of a spectrum, into mental illness. And this has been the predominant structure of our healthcare system, I guess, in many ways, hasn't it? That you sort of you're healthy until you meet some point, and now you're not anymore, and now you've got a mental illness, and we have services for that. Issues with access and stuff, notwithstanding. And this is kind of the thing that we're really pushing against with the Dual-Continua model. But I think just to clarify what we actually mean when we're talking about the relationship between illness and health, is kind of to start with some sort of almost philosophical understanding of the potential relationships between positive and negative. So this is something from James Pawelski at UPenn, which I found really, really useful during my thesis. This idea that there are basically three options. I guess I'm still simplifying this, right? But there are three options of how positive can be related to negative, just in general. And we're obviously making the analogy of positive being well-being, negative being mental illness. Negative is a bad word, positive is a bad word, but let's just sort of stick with it for now. So the option one is that positive is merely the absence of the negative. And that's something like the traditional thing. If you have no symptoms of a mental illness, then you must be mentally well. So on a number line, which is on the screen for those of you who can't see, that might be construed as thinking of -10 is the presence of a mental illness, whereas 0 is no mental illness, therefore healthy. I know my words aren't lining up exactly to the slides, but that's okay. The second is then, and the example here I think is something like, the relationship between heat and cold. So from physics, year 10 physics or something like that, the idea, it was a revelation to me, I think, that cold doesn't exist. It's merely the absence of heat. That's that option. I don't know whether that was surprising to other people or not, but it surprised me. Option 2 is that both positive and negative, that they both exist, and that they reflect polar opposites of the same spectrum. So this is that idea of extending the number line, which is, I think, exactly how Martin Seligman spoke about it when he was forming some of the big papers of positive psychology in the early years. This idea of, we have been focusing from -10 to 0, but that's not where the number line stops. You could actually be going now into the +10, which would be that presence of well-being. There are a couple of issues with that, which we'll get into in a second. But then the third option is this idea of well-being and mental illness, or positive and negative, as distinct dimensions. So these are then reflecting two separate continua, which we see on the next slide. So any comments so far? Special commentator, Stephen?
No, look, I think that's a good summary of the traditions and the way we've been thinking about this relationship between positive mental health or mental well-being and mental illness or mental ill health, or that end of the spectrum. The dichotomous model, the single continuum model in its various forms. Probably fewer people necessarily now adopt the dichotomous. It's either or.
Yeah.
And the single continuum spectrum model seems to be gaining more traction, but as we will see, it's not necessarily the most useful or accurate.
Yeah, great. I appreciate that. Yeah, I don't know why this popped into my head. I've just got to say it. But in Australia, we call the special commentators I think it's only in footy, boundary riders, which is such a weird, when you think about it, I guess it's such a weird name because they stand on the boundary of the pitch. And
that's right. They're just sitting outside the field of play on the boundary line, as we call it. And they comment from there, so they're boundary riders.
Yeah, it's just so weird. Anyway, whatever. All right, cool. So then this is the sort of the extension of that third option of positive and negative as distinct dimensions. This is then this idea of the Dual-Continua model of mental health. So under this model, this is some stuff I pulled from Heron and Trent in 2000. They're sort of suggesting that, when you think about these things separately, they weren't necessarily talking about the Dual-Continua model, but they were coming from this perspective of, if you thought about illness and health separately, you have these potential benefits. The first is that each concept can be described independently of one another and could be therefore tested and measured independently. Interestingly, I think they took that from a privacy perspective, which was, if you were to measure well-being, you don't necessarily then have to disclose anything to do with mental illness, which just was an interesting point. I think there are still many professions where, mental illness is stigmatized, almost like officially stigmatized in a sense, like when you think about judges and GPs and doctors and things like that. So that, there was a bit of a protection there, but I digress. The next was this idea that, under this assumption, it allows for the possibility that individuals can be mentally healthy and mentally ill at the same time. And Cacioppo and Berenson, which is another paper which we'll go into a little bit, which was really influential for me, talked about this issue of neutrality. And so what they were sort of basically suggesting, if we go back a slide and we think about that single continuum from -10 to 0 and +10, they're basically saying you under this assumption or under this model, we don't know what the 0 point means, that neutrality point. It either means you have no negative and no positive, but it also could mean that you have equal negative and equal positive. And we can't tell the difference between those two things. So it kind of masks this potential relationship, which I think now we are seeing, particularly for, as you said before, chronic or recurrent mental illness or permanent mental illness. There is a potential for improvements in well-being that you wouldn't necessarily understand. It's kind of masked by that issue of neutrality. I actually had this thing about it, but disclosing information about mental health, whatever. I should have read my own slides. That's okay. We'll skip past that one. But then there was this idea that this model, it provides the potential for new avenues for proactive rather than reactive mental health system design in mental health promotion. So it could potentially mean that we're less reliant on the labor-intensive downstream interventions, and therefore allows for this promotion to be more widely applied. Sorry, Stephen.
Yeah, look, I think also where, and we'll be talking about this more with some of the next slides, but the thing that, I think is important to get across is also that, mental health as, let's call it an umbrella concept, is we all experience a level of mental health or mental health in some form, right? So whereas the term now, in particular in Australia, mental health has more or less just become a low stigma synonym for mental illness. People don't want to use the word mental disorders, mental illness, because they think that carries stigma, and it does. But then they're talking about mental health, but that's confused everything, because it now is like equating mental health as a broad concept of, with a narrow concept of mental ill health or mental illness. So, because the thing is, we need to help the whole of the community understand, if we all have mental health, then we all benefit from initiatives that are designed to promote our mental health, protect our mental health, or help us recover from mental ill health. And it sort of stops us tuning off and saying, oh, that's a discussion for those people over there with depression and anxiety. That's not for me. I don't have those conditions. I don't need to hear about this. I don't need to engage with this. No, yes you do, because it's like physical health. Yes. We all have a level of physical health. It's not just people with diabetes or heart disease that need to talk about healthy lifestyles or not smoking. It's all, every single one of us. So I think this starts to democratise the concept and help people realise that this is part of the human experience. We all have a stake in this, and we got to stop othering mental health as if it's just about depression, anxiety, or conditions that group of people have and I don't have, so this is not relevant to me. It absolutely is relevant to every single human on the planet, and that's why we need to think beyond just a simplistic either-or model.
Yeah, perfect. I love it. And then, so this is my, just as a side note, I think maybe we've elabored this point a lot, but it's so interesting to me that when you use the physical health analogy, it makes perfect sense. Like the difference between how the average person on the street thinks about physical health versus their mental health is just so different.
Very different. And it's there's no one out there that would say it's not a good idea to stay physically fit and healthy and well, and almost everyone does something in their day to look after their physical health. Now, a lot of people are doing stuff to look after their mental health, but they don't even realise that that's the connection. So we have to make what's implicit explicit and help people to join the dots. And, in some ways, the physical health model, it's not perfect, but at least it's a point of reference that people are familiar with that I think we can leverage for these sorts of conversations.
Yeah, perfect. And then this last point here is the bit that's really exciting to me, I guess, and really opened my eyes. I think, again, I got it from the Cachopo and Bernson, that this idea of thinking about mental health this way allows us to identify unique antecedents and predictors. And I think this is the bit, again, a little bit like that issue of neutrality, the 0 point. By adopting this kind of, we call that the bipolar model, so that option 2 that we just discussed, that sort of -10 to +10, you're masking an understanding of what are the things that promote well-being, which may potentially be unique compared to those that reduce distress. So in another way, the things that make you happy may not necessarily equally make you less sad. Again, that's a oversimplification, but it's that idea that there may be things, and I think there are a couple of papers that have investigated this and shown that there are things that more uniquely affect one over the other, but because we've thought about it as a bipolar model, we've just overlooked that opportunity. And so if we go all the way back to that call from the US Burden of Disease collaborators, that idea of programs to prevent mental disorders and to promote mental health, we don't really know which does what at this point. And I personally would put that down to this idea of us not having had the sort of the theoretical opportunity to identify those unique antecedents and predictors. And again, going back to your physical health, we all know that the things that promote health are not necessarily the things that that reduce the symptoms of disease. I mean, often they are overlapping, but sometimes they're not. And it's that nuance, I think, that's really useful.
Yeah, for sure. I think it is exactly that. The nuance is very important. You know, as you say, some things that we do will assist with both promoting mental well-being, reducing distress, but as you say, other things are probably more unique to one or other aspiration.
All right, and so the diagram that you see on the slide is kind of like your old X and Y math diagram. I'm going back again to year 10 for some reason today. Or probably hopefully earlier. I think you should know about that. But that idea of, like, you know, you have one axis which is your level of distress and one axis which is your level of well-being, and that's more commonly depicted as you see on the screen now. So kind of like it's obviously the same graph, but it's not meeting at that sort of intersection of zero. They're crossing over, and this is how we often see the dual-continua of mental health depicted. So you have that one axis saying, you know, maximal psychological distress, absence of psychological distress, or, you know, I'm using these as synonyms of mental ill health or a diagnosis of mental illness, and then the other axis of maximal or optimal well-being and the absence of mental well-being.
Yeah, and I think, you know, this is the same way, but as we'll see, you know, it breaks the population up into, you know, potentially into quadrants that we can allocate people to where they sit on the x-axis and the y-axis. But basically, yeah, the concept is that we can vary at any given point in time. Each and all of us will have a certain level of mental well-being, from low to moderate to high, and a certain level of mental ill health, from maybe no symptoms, mild symptoms, moderate, severe symptoms.
Yeah.
We need to sort of understand where we sit on both of those spectra to be able to get a proper gauge of, you know, our overall mental health.
Yeah, exactly. And then that idea that, you know, obviously mental well-being is not one thing and distress is not one thing. There are various aspects that inform each of these things. So that's where I say it's still a simplification in the sense of, you know, it's not really like I've got a score out of 10 for one and a score out of 10 out of the other. There are multiple dimensions of each of these things. And that's probably the next level of understanding how do these various dimensions interact with each other. But at a more general level, I think that's
this is an aggregate of the total of the various sub-dimensions that you're presenting.
Yeah, absolutely. And so I'll bring up, I'm going to skip around with my slides a little bit. This is something that I used for a competition that's called the 3-minute thesis, where you have to describe your PhD thesis in just 3 minutes and you get one slide, no animations. It's a really great challenge. I think it actually started in Queensland and now it's a worldwide phenomenon. And it's just such a great challenge for students to you know, basically they've been thinking too hard about this problem. They've become verbose. How can you narrow it down to 3 minutes? Anyway, this is a slide that I was using. It's got the dual-continua, obviously, and it's got those 4 quadrants that you spoke about. And I kind of thought, to get this across in 3 minutes, let's kind of go with these cartoon characters. It's, you know, obviously, again, like I say, if you're looking at Simpsons characters, you're not looking at the most rigorously defined scientific thing of all time. But this is kind of where we go. And I'd like to hear sort of how you think about your work in this context. So just quickly, for those who can't see it, you know, when you think about, if you have an axis of these quadrants of high and low well-being, high and low mental illness symptoms, again, I'm going to stop saying this now, but this is an oversimplification. It's not that it's true that there are these 4 groups of people. That's not what we're talking about here. This is a diagram. You know, we've got Bugs Bunny, who's sitting pretty. He's got high level of well-being with no mental illness. That's kind of the optimal state. We've got old Gil from The Simpsons, who, for those of you who remember this guy, it's like low level of well-being who wouldn't be diagnosed with a mental illness sort of yet. and that's kind of, you know, the guy who's just life's not going well. Corey Keyes talks about this as the languishing group, the feeling of blah. We've got Eeyore, who you know, is someone who has a low level of well-being and you know, the presence of a mental illness. And then this is the hardest character to find, and it's not. It's just because we don't talk about this group of people, basically. But someone like, I've got SpongeBob here in the top corner, who has a high level of well-being and, you know, the presence of a mental illness. You know, maybe going into the mania sort of thing, but it's a character that we just don't really demonstrate, because it's a bit of an invisible subgroup, isn't it?
Yeah, look, and I was wondering what SpongeBob, why you chose SpongeBob for that, but absolutely, this is a very you know, interesting part of the quadrant, and you know, clinicians will be able to, and people with lived in living experience will definitely be able to identify, you know, themselves or people they know on this quadrant. I mean, absolutely, there are, you know, certain mental health conditions that are, you know, relapsing, remitting, or have persistent symptoms, and then you could fall into the trap of saying, well, that person is, you know, mentally unhealthy. Well, but they're not. You know, they may have some ongoing symptoms of, you know, generalized anxiety disorder, or some dysthymia from, you know, depression, or you know, even persistent auditory hallucinations from schizophrenia. But that does not mean that they cannot experience good emotional, good social, good psychological well-being. And, you know, the data shows that there actually are people in that category. And so we, you know, this is very much aligned to the concept of recovery, that it's not all about symptom remission. It's about being able to re-engage with your community, your, you know, social and economic participation, you know, have those social connections, have a focus, meaning and purpose, something to do in life. And if you've got those, well, you've got a certain level of mental well-being, even though it might be impacted somewhat by the symptoms or the difficulties you may be experiencing from, you know, a mental health condition that you have, some of which might be, you know, heavily genetically sort of influenced. So this is a great, you know, part of this model, in that it provides a certain level of hope, but also a certain re-emphasis on what we need to provide at the service level, you know, for people who may have more enduring or persistent symptoms of mental ill health. It's not just about medications and CBT. There's other things we can offer that are going to improve people's mental well-being, quality of life, call it what you will, even if you can't necessarily, you know, cure that condition or reduce all the symptoms of distress and disability that are associated with it.
Yeah, and so, like, you know, in our work, I think we particularly are really focused on the old gills of the world. So this is the people who we often have like a little ninja emoji that pops up next to old gill there, because this is the group of people who sort of fly under the radar of our health services. That's how we sort of describe it, that because we're not assessing well-being, we often don't see this group of people, because they don't ever meet a clinical threshold, or, you know, until they do. But there's a few longitudinal studies from around the world showing that, you know, this group of people are up to 8 times more likely to develop a mental illness in the future. And so, and we just don't really have much for them at the moment.
Yeah, that's right, because they're not a group that we you know, some terminology would say, oh, well, you know, this is subclinical mental illness, you know, you've got a sub-threshold condition, but it's still mental illness. But I think it's a different experience again. You know, I think, look, I live in Melbourne, in Victoria, and as most people would know, we were the most locked down city over the sort of the 2020, 2021 sort of COVID period. And you could see as a community, because we had so many of our protective factors stripped away from us, our ability to connect with others, our ability to go out and, you know, pursue our livelihoods, you know, connect with others, etc. But, you know, I don't think many people would have necessarily, suggested they were experiencing depression or anxiety or a formal mental health condition, but they were certainly in that blah category. There's certainly that feeling like, we were in a rut, we had suboptimal mental well-being, but we may not probably, and a lot of people didn't necessarily have, a diagnosable mental health condition. Some did, and so I think it made people realise, I think the penny did drop for a lot of people that actually, we do have a level of mental well-being, and our mental well-being does matter, and actually it's pretty fragile, and if we don't look after it, if we don't have the right sort of protective factors around us, it can actually suffer. And there wasn't really a lot for people who were languishing out there. I mean, yes, we tried to beef up our mental health care services for people in the bottom left quadrant, great, but there was very little on offer for the people in the languishing group to get them back up to the flourishing, optimal mental health end of the spectrum. So they are definitely an ignored part of the spectrum.
And so, I mean, I had some more slides, but I think we can just stay with this one really to just talk about the rest of it in the context of these four characters, just to sort of make it a little bit more palatable. If you look at this diagram, I guess, again, I'm making you look at four cartoon characters, but what of the work that you're advocating for, what do you want to see?
Well, so I think this gives us a goal, right? What is the whole point of mental health policy? You can either decide, all right, well, mental health policy is really only about, supporting people who are experiencing, mental health challenges. That's our only obligation. So we're going to support the people in the bottom left quadrant. That's all we need to do. But if we take a more global, comprehensive, holistic approach to mental health policy, we say, no, actually what we're trying to do is to get as many people as possible, as close to 100% of the population, into the top right quadrant. So not only do we need to, we need to first and foremost promote mental well-being, as an independent construct in its own right. How do we get people to experience optimal or high levels of mental well-being? But of course, then we need to also try to diminish or prevent the occurrence of mental ill health or diminish its impact, the severity of the condition. And that then gives us two things we need to do, not just one. And so it's about then taking a whole of population perspective and saying, how do we optimise everyone's mental well-being, whilst at the same time also supporting people experiencing mental health challenges through their recovery journey, either up to the top left quadrant or to the top right quadrant, depending on what we can successfully achieve.
I'm going to make you say the characters' names as well, for the people that aren't watching this.
So we need more Bugs Bunnies hanging around, people who are chill and have leaving fulfilling and contributing lives, high social, emotional, psychological well-being, and we've got to support people who are in that Eeyore quadrant to either experience reductions of mental ill health symptoms and move up to the SpongeBob, quadrant, or better yet, from the SpongeBob quadrant to the Bugs Bunny quadrant. Yeah. And we also have to help people in Old Gill. I mean, Old Gill is suffering. He is not necessarily in a good place, psychologically, emotionally, socially. But he's often ignored. He's overlooked. He's just said to be in a rut, the worried well, something, derogatory. But his suffering is not acknowledged. And we also need to help the Gills of this world move up to the Bugs Bunny quadrant, if we're using that analogy.
Yeah, and sorry to make you to drag you down to my level of talking about cartoon characters. But yeah, no, that's exactly right, and that's the picture here, isn't it? So I'm looking forward to having an episode in the future with Chiara Rini, who's in I can't remember actually if it's Riuni or Ruini. I'm sorry, Chiara, but I'll get that right. She's in Italy. She's a clinical psychologist who's worked with Dr. Fava, and they've really, like, you know, in our cartoon character world, they're really focused on how do we turn Eeyores into SpongeBobs. Basically, that idea of how can we promote well-being as a valuable end in its own right for those with a diagnosed mental illness, and I think that does become an avenue for recovery in the future, and I think it's like you said, it's a valuable. I mean, it's valuable in its own right, basically, because I think you would rather be. I mean, we can even. I sort of toyed around with having Eeyore in both quadrants, but Eeyore with, like, you know, Winnie the Pooh and everyone else around him, because some people do use that as a nice example or an analogy of, you know, having a bunch of friends, maintaining, you know, meaningful relationships, being supported by those around you, despite the presence of a mental illness. You know, kind of could have been both, but that idea of for those for whom recovery is possible, you know, like clinical recovery. You know, that idea of, at least Kiara's work indicates this idea of pushing, you know, Eeyores up into the SpongeBob world, and then eventually becoming, you know, somewhere like a Bugs Bunny. But for those for whom recovery is not possible, like in the idea of a clinical recovery, so you know, having not being diagnosed with this thing anymore. It's just a more optimal place to be, basically. Like it's a better, and they call that idea of personal recovery.
That's right, exactly. And personal recovery is different from clinical recovery in many ways, but it's self-defined. But it is also about you know, your life as a whole, and you know, not your condition or your illness. So you know, I think what we're seeing, for example, you know, after the Royal Commission here in Victoria, there was a subtle but very important name change. You know, the Royal Commission said one of the first things they wanted to see was to change the wording from the mental health system to the mental health and wellbeing system. And that sort of subtle change says, all right, well, okay, we're you know, by mental health they really meant mental ill health, you know, distress system, to a mental distress and wellbeing system. So it suddenly adopts that language of we have to focus on both. Now, I think services are still trying to unpack and understand what the implications of that are, but it's almost like taking the Dual-Continua model and applying it at the service level and saying it's not enough to reduce people's distress, you know, through you know, pharmacological interventions or targeted, pharmacological and psychological. There's something else that needs to be added to the mix, and these are these sort of wellbeing supports. And as you know, they revolve around things like, you know, self-care, social connectedness, social and economic participation. You know, the other things that are about your life as a whole. And these new service structures that are supposed to be evolving in Victoria, called local mental health and wellbeing services, have to put equal weight on the wellbeing side of the equation as the distress reduction side of the equation. So it's going to be really interesting to see how they evolve and how they incorporate this sort of logic into the work they do, because unfortunately the old-fashioned system has been dominated by case management, medication. You know, some people get psychological therapy type of model. And that's why they're experiencing incomplete recovery. They're getting maybe symptom recovery, but not personal recovery.
Yeah, and obviously then this applies broader than just you know, the sort of the treatment world or the intervention world. This also applies at the socio-demographic level as well. So the environment around the people, so you know, housing, transport, everything else, right? Totally.
So this is the thing. You know, this is a blueprint for whole of population, you know, interventions. The working with individuals, teaching them the skills to support and protect their own mental health and well-being, but also changing environments around them, whether that's family environments, school environments, workplace environments, or the broader social and economic environments. We have to act at multiple levels to get everyone into the Bugs Bunny sort of top end of the spectrum. It's not one-to-one. Stuff is not on itself enough. We have to put in place certain programs and change certain public policies to support people's mental health and well-being. And so but you can then, so you can apply this model both at the population level, but you can also apply this model at the individual and, level for people who may have a diagnosed condition. So it's got great utility to guide intervention both for one-on-one type of work as well as whole of population type of work.
Fantastic. All right, so I had some, I'm just going to go through them quickly just to show people that I had more serious looking slides. I did actually have them, but I don't know, I'm not that serious of a guy sometimes, but I think this has done a great job. I'm just thinking, what did we miss on these slides? The idea for me, the big implication here is that we need to be assessing mental well-being as well as levels of distress, because if you're only measuring one or the other, you're only looking at one of these axes, and so you've lost really valuable information.
Yeah, I think, what we need to do is change our thinking and the way we engage people, and the way we conduct our assessments, as you say. And, when someone's coming to you because of distress, of course you need to, understand that the level of distress, the level of risk associated with that distress. But you're right, you're only getting part of the picture if you just measure K10 scores or, the DAS-21, stress, anxiety, depression. You need to measure mental well-being as an independent construct in its own right, because that will both guide, intervention. But you also, I think, need to assess for, and this is what we used to do in, mental health psychiatric formulations, right? It wasn't just about diagnosis, it was about understanding the person, their life, their experiences, the so-called, predisposing, precipitating, protective factors. And we need to better assess people's life circumstances and what are the risk and protective factors that have brought them into this through this gateway into a clinical service, because we can also then help them manage those risk factors that might be contributing to their problem, whether that's financial difficulties, whether that's housing difficulties, whether that's relationship difficulties, at the same time that we're trying to optimise mental well-being and reduce mental distress. So a comprehensive assessment requires an assessment of well-being, distress, and risk and protective factors.
Yeah, amazing. So I'll stop sharing now. Great, Stephen. Thank you very much. You just a last question, I guess. You have set yourself up in a really interesting position because you're independent, and you sort of, I don't know if you would call yourself this, but like in a sense, you've got nothing to lose in a way. You're out there on a mission, and you don't have, any overarching things imposing or getting in the way of that mission. And I think that's a really unique place to be. I think it's extremely uncommon. The last question, I guess, is what are you most hopeful for? We're talking about, we've talked about a lot of things that we would like to see in the world. What do you think is the most immediate or the best chance?
Yeah, look, great question. And look, you're right. I mean, I think when we first set up, we did have this idea that we would be one of the players offering, wellbeing and prevention programs to the public. But we've decided to maybe pull out of that space because I think there are a lot of great people doing great work like, yourselves on this. So, yeah, we do want to play more that strategic influencer advocate sort of role, like a quasi-peak body for this concept of mental health promotion, illness prevention. So what am I hopeful about? Well, I am an eternal optimist, and I do think we're starting to see a change in the language and a change in the way we're thinking about this. And I think the Dual-Continua model has actually helped quite a lot to change people's thinking about that. So I think we're getting away. We're trying to break down this either or. Let's stop competing. Let's work on this together. You do your thing, we'll do our thing. Let's see where we can collaborate and integrate, but at least don't compete. And I think we're starting to see some changes. We work with clinical service people as well as mental health promotion people, and we've been able to bring them together and they collaborate and cooperate. And I think, as we've seen in Victoria, this concept of mental health and well-being has sort of, started to influence mental health care services. We're seeing a similar thing in Queensland. And I think, as I said, we're also starting to see promotion prevention get back on the political radar, albeit still just at a state level rather than a national level. So, and I think we're seeing continued great research. We're understanding these issues better. Where we're at now is we just have to start the journey. Like, you'll never get to your destination if you don't get in the car or the bus or the tram or whatever it is, actually, and start the journey. And then once you're there, you'll find your way. You'll get there eventually. It might take a little bit of time and, whatever. But at the moment, it felt like we weren't even bothering, doing anything about this. Well, at least we're now in the car, right? We've moved beyond pre-contemplation and even contemplation into action. We're on the road. Now, where it's going to take us, I don't know. But if you had this interview with me in another 10 years, 20 years' time, it would be a very different world as long as we kept driving forward. And don't look back and don't stop the car. Just keep going, learn as you go, and we'll get there.
Fantastic. All right, very cool. Thank you very much, Stephen. This has been really fun. I didn't expect probably that we'd be talking so long with cartoon characters on the screen, but I'm kind of happy that we did.
Well, it's a good way of introducing the concepts, particularly if we're talking to a younger audience, which we need to do.
Yeah, absolutely. I'm not sure. I don't know whether these things even resonate anymore with young people.
Yeah, those characters are probably a little bit old school, aren't they?
Probably. All right, awesome. Thank you so much, Stephen. Thanks again for your time, and we'll talk
cheers,
to you
Matt,
soon.
and great work that you're doing, and keep it up. This is a fantastic series. Well done.
Great. Cheers. Bye-bye.
Bye-bye.
Thank you to Stephen Carbone for being a part of this episode. I hope you enjoyed it as much as I did. What I thought I would do, just to finish off, is to go through those slides that I sort of brushed over when I was with Stephen. I think we covered most of these points, but I just thought, the slides are there, so I might as well cover them off. So when we're talking about the Dual-Continua model, we're really talking about these three big implications, basically. And the first one was around measurement, which I think Stephen, really succinctly nailed. But really, what the evidence is suggesting is that the measurement or the assessment of mental illness alone does not provide an indication of mental well-being. And the opposite is also true. If you're measuring one or the other, you're not getting the full picture of someone's overall mental health. And so when we're wanting to assess overall mental health, we need to be measuring both of those things. But what's really interesting about this idea of the Dual-Continua, obviously we've said already that this sort of X and Y axis graph sort of thing is still a simplification, but just bear with us that, under this idea, you get these four subgroups that can be formed. Those with high, we've already talked about this with the cartoon characters. But the idea is that it starts to identify these previously invisible subgroups. So, again, this is some data from us, from some of our Australian work. It's obviously sort of estimates of how we sort of start to see the proportions of these groups in our community. We've got the little ninja emoji for that vulnerable group. So, who are up to, somewhere between 20 and 30% of our population. So they wouldn't be diagnosed with a mental illness, but they wouldn't be said to have a flourishing level of well-being. So either moderate or languishing. And these people are flying under the radar of our services. There's this idea that complete mental health, some people don't like the language of complete, and that's completely fine. Completely fine. I don't care about the name here. What it means is that the ideal state is obviously to have a high level of well-being without distress. And I say ideal in the sense that this is a group of people who are less likely to have a number of other sort of negative outcomes in their life occur. So that's kind of where we'd like to be ideally. We see that these groups can be transient, as particularly that vulnerable group, and we saw that in our data as we followed people throughout the COVID pandemic, that actually people could move from that vulnerable either across into the a distressed population or actually up into flourishing as well. And so the point there is that none of those things are possible without the assessment of both well-being and distress in some form. The second implication was around intervention. And so interventions that are designed to improve mental health or mental well-being or positive mental health, and those that reduce mental illness are not necessarily the same thing. So they're complementary, but they're different. We don't know a lot about this, I don't think, at the moment, other than the fact that we've seen that some interventions improve well-being without a change in distress, and the opposite is also true. So a positive response in one dimension does not guarantee a positive response in the other. And again, this is nuance that you don't see if you're just measuring one or the other. And so the idea here is that under the Dual-Continua model of mental health, we can start to understand person-to-intervention fit. So matching exactly what are the components of an intervention that a person needs, whether it be either, as you see on the screen, to improve their well-being only, if they were, say, in that languishing, vulnerable group, or if they need, if they would benefit from both the reduction of distress, but also the promotion of mental well-being at the same time. Or, does that happen in a staged way? Does it happen at the same time? We don't know what works best at the moment. The idea here is that different people in these different categories might require different types of interventions, and we can improve that fit by better understanding their overall mental health and well-being. And the last one was really about system reform, the last implication, the idea that these different subgroups have different risk profiles. So we've said before that those who are languishing are almost over 7 times more likely to develop a future mental illness. And again, they're flying under the radar of their services, so we're not really focusing on how to reduce that risk. So there's a huge piece of work that can be done there around identifying risk and putting in more targeted prevention. And I guess you can call that early intervention if you like. But then there's also applications for things like stepped care models, which we have in Australia. So the idea that that care and services that are available to people should be sort of stepped and matched to intensity of the issues that they're facing. And the idea here is that at the moment, the early steps, like the low intensity steps, don't really have much in them, and that they could actually be filled with lots of different well-being interventions as a protective factor for future mental illness. And then the final one is this idea of integrated care. So, this idea that well-being could become a therapeutic avenue to enable recovery. And as I said during the podcast with Stephen, that there are researchers around developing things such as well-being therapy, which are clinical applications of well-being and positive psychological interventions. So the idea that the promotion of well-being can be useful for recovery. So, in summary, well-being interventions and measurement needs to be embedded or should be or could be embedded within the mental health care system for both prevention and recovery of future mental illness. So again, thanks all for listening. Like this episode if you'd enjoyed it, or even if you don't, just like it anyway. Share it with someone that you know. Subscribe to the channel so you don't miss out on future episodes. And thank you very much.